Good afternoon, good evening, and good morning, everyone, from wherever you are joining us today for this webinar. This is the second in the series. We are running a series of 6 webinars around medication safety, focused on the theme that has been declared by the World Health Organization for this year's patient safety. So today is 23rd, and we will be today discussing with 4 eminent panelists on 4 topics on how can healthcare professionals help in prevention of medication harm. And when I was preparing for this webinar and going through the material, I chanced upon a report called Medication Errors, which is a technical series on safer primary healthcare by the World Health Organization in 2016. And it says that there is no consensus about the definition of a medication error. A systemic literature review found 26 different terminologies employed for a medication error. And therefore, to collect data and to actually understand what is the volume of medication error and how many people are harmed by medication errors is really difficult because of a lack of a uniform definition. The United States National Coordination Council for Medication Error Reporting and Prevention defines the medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or the consumer. And such events may be related to professional practice, healthcare products, procedures and systems, including prescribing, order communication, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. So it's a wide range and a spectrum of places and procedures where the medication error can happen. And as we know that when the patient is in the hospital setting or a healthcare setting, they are in the care of trained professionals. And how can we prevent medication harm when they are in the care of trained professionals is the topic of discussion today. So there are several factors that are associated with medication errors due to in healthcare settings where there are doctors and nurses. And some of these could be lack of therapeutic training and inadequate drug knowledge and experience, or inadequate knowledge of the patient and inadequate perception of risk. It could be overworked or fatigued healthcare professionals. It could be physical and emotional issues of the healthcare professionals themselves while they are at work, and poor communication between healthcare professionals and patients. It could also be related to the patients themselves when they are within the healthcare system. And this could be characteristics that are unique to the patients, like the cultural context, personality, literacy, language barriers, etc. And also, if the patient has several clinical conditions, it could be the use of many medications and confusion on the part of the patient leading to medication errors. So without much ado, I would like to introduce our esteemed panelists today. And our first speaker today will be speaking about education and training for healthcare professionals in ensuring medication safety. And he's a renowned person in quality and patient safety, especially in the context of India. He works with the National Health Systems Resource Center as an advisor, and he has an advanced qualification in medicine and health systems management. He leads quality and patient safety initiatives for public health systems in India, and he's an elected member of the National Academy of Medical Sciences and the founder member of Indian Society of Hospital Waste Management and Health Systems Action Network. And he has several published publications in peer-reviewed journals to his credit. Welcome, Dr. Srivastava. Our second speaker is Ms. Shanta Sahu. She is the Chief of Nursing at AMRI Mukundpur, Kolkata, and she will be touching on the topic of communication and teamwork among healthcare professionals. She has previously worked as Principal, Royal College of Nursing and CMRI School of Nursing, Kolkata, She's worked as a CNS, Chief of Nursing Services at Columbia Asia Hospital in Salt Lake City, Kolkata. She's worked as a lecturer and coordinator for the 4th year BSc Honors Nursing Program at BM Birla College of Nursing from August 2010. Worked as a clinical supervisor at the BM Birla Heart Research Center and a national winner of the 34th CII Quality Circle competition from the AMRI Hospitals, Mukundpur, Kolkata. So welcome to you, Ms. Shanta Sahu. Our third speaker is Mr. Howard Curtin, and he is the CEO of International Council of Nurses, and he will be touching on the topic of capability of point of care. He is a very renowned person, and he is well known in the circles of quality insurance. And throughout his career, Howard has worked and written extensively on issues relating to the nursing and healthcare workforce, and he has co-chaired the first ever State of the World's Nursing Report. He joined ICN in April 2016 as the Director, Nursing Policy and Programs, and his team led the development of ICN policy and position statements. He studied social policy at Cardiff University and industrial relations at Warwick University, and then worked as a personal and organizational change manager in the National Health Services in the UK. And for 10 years, Howard was head of policy and international affairs at the Royal College of Nursing in the UK. We have a recorded message from Howard, as he has been unable to join us physically due to work commitments. And our speaker for incident reporting and learning is Ms. Arshia Bhandari. She's a patient safety advocate and a pharmacovigilance expert and a founder of PHV Fit. She has been in the field of pharmacovigilance for the last 16 years and has worked with blue chip pharma companies on end-to-end pharmacovigilance processes during her journey with Quantum Solutions India and Paraxel International. PHV Fit is an initiative to bring positive transformation in our healthcare system by empowering patients and healthcare workers through understanding of the patient safety principles and challenges. She's also a certified business storyteller and coaches NGOs on storytelling for impact. And her article on patient safety efforts in India was recently published in the Uppsala Reports, a WHO publication, and talked about the patient safety initiatives in India and the way forward. So welcome to all our panelists. And I now hand over the floor to Dr. J.N. Srivastava to make his presentation. Over to you, sir.
Thank you, Dr. Ratna and the colleagues. At the outset, I am extremely grateful to have been invited to speak on this August gathering on the education and the training, which is so vital for the delivery of the healthcare, and that is where the patient safety, issue of the patient safety, and more so the medication safety, they are embedded with. And in that context, all of us are too aware that the healthcare delivery is, after all, a team effort, whether the delivery takes place within a facility, whether the primary care, secondary care, or tertiary care, or even in the community setting, which the government of India, in fact, last 4 or 5 years, through the mechanism of health and wellness centers, is trying to deliver. More so when we talk about the palliative care or the elderly care, and these are the patients which cannot be kept too long in any institutional setting. And that is where perhaps my concern also emanates somewhere, because all of us are aware that in India and in many developing nations, when the UHC agenda is being put forth and taken, we have to be doubly conscious of the fact that it also entails certain possible situations where the patients may experience harm, more so with the medication harm, where the patient's vitals are changing. And that is where perhaps creating that kind of knowledge, skill becomes so important if we are serious about addressing this issue simultaneously. Because it becomes important that we remain proactive, we are fully aware that what is taking place, and take the subsequent actions accordingly. Otherwise, this may become a bit too late. I hope my screen is visible. So in this context, all of us, we know that out of all the living beings, in fact, the humans, they have that capacity, they are bestowed with that capacity to administer the medicines. And as we mentioned, that in the facility-based care, it is no longer that the doctor writes the prescription or the pharmacist dispenses for the OPD patients or for the indoor care. It is one person or a group of persons remains responsible. It has to be a team effort. And similarly, I will touch upon the role of the frontline health worker, community health workers, and the multi-purpose worker, more so in the Indian context. And with all these things taking place, somewhere the role of the family and the person themselves, when the country is making a progress towards increasing longevity of the life, and with the more people having the lifestyle diseases or the non-NCDs, burden of the NCDs increasing in the country, where a person is expected to be self-administering the drugs, whether it is insulin or for other set of diseases. So in this context, in the interest of time, we want to leave some time for the discussions, and it becomes important. And what we realized, and while looking at the spectrum or the horizon, first and foremost important, like after I received this invite, I had been trying to go through the syllabus or the training curriculum of different professional courses, and whether it is for the medicine or for the nursing professional or for the other allied sciences. Somewhere one of the foremost gaps which comes in the forefront is that there's a complete sense of unfamiliarity on the part of the trainers or the instructors in imparting the knowledge and the skills. Because like traditionally, I being a practicing doctor till a couple of years back, I can share that we all were taught, and so our colleagues, those who have undergone the formal, say MBBS or the MB qualifications or the nursing professionals, we were taught that, okay, these are the drugs which are indicated for a particular condition, but hardly the discourse on the drug interactions, how these drugs are going to interact with each other, and what are the precautions which needs to be undertaken. This was largely left in somewhere in the passing. I am very candid about that in sharing, somewhere in the passing at end of the particular lecture or the demonstration which used to take place during my time. I'm not too sure whether the things have changed at this point of time or not. Similarly, all the professional bodies, they have enacted that there is a requirement of certain credit hours which they got to be having when we go for any renewal of the certificates or our practicing licenses. But still, we don't have any structured format that out of these many credit hours, at least this much minimal should be devoted for the pertaining to the medication or the patient safety in the larger canvas. These are the challenges. So somewhere it becomes required that if we are serious about addressing this major gap or the lacuna in the system which is coming up, somewhere the professional bodies are required to be coming on board. Third important thing which came to my mind, because we are also working on the coming out with the essential medicine list for each of the states, for each level of the facilities, other than based on the NLEM, National List of Essential Medicine 2021-22, which has been in fact in principle approved. But like each hospital is supposed to having its own formulary, its own essential drug list. But I doubt that when some new staff joins, that whether he or she gets oriented or whenever some revisions in these formularies or the list have taken place, whether some kind of orientation has been undertaken. So these are the challenges which are coming up, and that is where this need of having the continuous, it should not be only continuing medical education, nursing education, or whatever one wants to call. The basic need which remains important is building the knowledge base, number one. But another concern comes up that merely building the knowledge base all alone is not going to serve the purpose, or one time conducting a training or the whatever is required to be done will not solve the problem. So the second, in fact, the important facet is how do we bring about the attitude and practice. Somewhere we have to be looking at holistically in terms of the KAP, that knowledge, attitude, and practice, so that whatever the knowledge has been acquired, it becomes the part and parcel, or it becomes the part of the DNA of the working of that individual or the professional, and it gets practiced. Somewhere those things are also going to be the important. So towards the end part of my talk, I just want to add on that we need to be undertaking the actions at multiple levels, be it at say any professional college. When somebody enters at the age of 17, 18, 19 years, when one gets exposed for first time as a part of the professional training, whether it is the doctors, nurses, or other professionals, the medication safety has to be well-defined entity of all the clinical trainings, and that is the need of ours. It cannot be, with due respect to our colleagues from the pharmacology department or the clinical pharmacology, it cannot no longer remain one of the, in fact, somewhere being touched upon during the course of clinical pharmacology if we are serious about doing this. Then second important thing is that there is a need more so in the primary healthcare, and more so it becomes important under the UHC agenda, where all the primary healthcare services are being strengthened across globally, more so in India and other developing nations, that besides imparting the knowledge and skill that what are the indications, what are the contraindications of the drugs, but at the same time it becomes important that how a particular drug is required to be, in fact, managed. When I use the term manage, I'm using it very consciously. When I talk about the management it starts from even how the drug has been stored. I'm witness, I'm not sharing, I'm not going to name those health facilities, but I'm witness to a couple of health facilities where I visited personally. And I found that whole lot of the drugs, including the high alert drugs, have been kept haphazardly without any mentoring or the guidance support being available. And this cannot remain one-time activity. It has to be an ongoing effort on the part of at every level, whether it is at the sub-district level or the block level, depending upon our state's nuances, or the national level. These kinds of mentoring support has to be required. As of now, in fact, I'm sorry, I may be touching upon other speakers' domain, but that is a concern which I can't resist from the sharing, that it will be important somewhere, and that we create an enabling environment, that culture of punitive actions being taken, we have to be doing away. That poor CHO, my heart bleeds for him or her, that he's all alone, and he's trying to figure it out, that if I report something, if I notice something, there is a likelihood that this license may get cancelled, and I may be posted back to my parent cadre from which I have been drawn. So then creating, say, awareness on the part of the ASHAs, on the part of the ANM, when we are professionally training them, when they are visiting a patient who is, who is on the palliative care in certain states where they have enacted upon the rules that narcotic drugs could be administered in the home settings, in the domiciliary settings, it becomes important that they feel that, okay, there is a kind of thing. These things should be required. So broadly, just to summarize my talk, that at the national level, it got to be required, the medication safety related issue in the curriculum of all the professional bodies. Then we got to be establishing certain, say, collaborative centers, certain centers for excellence, where the people can learn firsthand. Since the requirement of in a large country like India, the health systems requirement in each state varies. And within the state also, if I talk about the large state, say state of Uttar Pradesh, which is the 1/6 population of the country, the ground reality in the West Uttar Pradesh and in the East Uttar Pradesh are quite different, including the disease burden. Like filariasis or the Japanese encephalitis syndrome kind of conditions, which are so common in the Eastern UP, same may not be the case in the Western UP. So we got to be, even at the subnational level, at the state level, certain actions are required. And as I mentioned, as I requested, that all the professional bodies, they got to be bringing about certain specialized credit hours pertaining to the patient safety, and also within that subset, certain credit hours on the medication safety for each professional category got to be included. At the facility level, at the hospital level, or the health center level, there is a need to undertake in a formal way the training need assessment, and it cannot be one-time training. It has to be an ongoing effort. So one part is that building upon the knowledge, but at the same time, certain softer skills should be required, certain to build upon, so that this translates into their attitude and day-to-day practice. And last become important. I mean, the last point, again, at the cost of repetition, I'm again, in fact, highlighting the need for having an enabling environment. If we address these 3-4 issues, and we have got a subject matter expert on the pharmacovigilance, and we look forward getting her input as well, so that the things gets reported, and more importantly, that it is not only the reporting, but certain say follow-up actions, certain say preventive actions are undertaken, so that these preventable harms are required. So once again, thank you very much for giving me this opportunity, for sharing me, for allowing me to share my thought, and look forward to working together in time to come. Thank you very much indeed.
Thank you, Dr. Srivastava. And very important points that you raised about an enabling environment, continuing education, and also shifting of healthcare from hospitals to communities, especially with longevity increasing and lifestyle diseases becoming rising to a pandemic proportion, and palliative care happening at home settings. It is important that frontline healthcare workers are also taught about medication safety, lack of curriculum around patient safety and medication errors in particular, and also the need to have continuing medical education with mandatory credit hours, so that the training does not stop as a one-time exercise, but continues through the course of the person's career. So thank you so much for highlighting these points. And we will now move on to our second speaker, which is Ms. Shanta Sahu, and she will be talking about communication and teamwork among healthcare professionals. We know that nurses are the backbone of healthcare. They are the ones who administer the medicines to the patients and explain how medicines have to be taken. So over to you, Ms. Shanta. Shanta, are you speaking? We can't hear you.
Yeah, thank you. Thank you, Madam Dr. Ratna. Can you hear me? Thank you so much. And thank you for giving me this opportunity to be in this gathering, such an August gathering. And I would just like to highlight that it is because of communication that I am able to be with this August team. Otherwise I wouldn't be, because somebody referred me. So you can understand how is communication so important. And I was amazed by the quickness, how fast this program was scheduled, and team members agreed to it. So that is why I have in my further slides, I have inculcated the word catalyst. Communication, yes, we have become very fast in our communication. We have become soft skills trained and everything, but we have to know how to do it in the right way, at the right time, at the right situation, to bring about collaborate the safety when we talk about providing quality healthcare. Thus, so why is communication and teamwork so important? Aren't they correlated? Obviously they are. Patient safety experts agree that communication and teamwork skills are essential for providing quality healthcare. When all clinical and non-clinical staff collaborate effectively, healthcare teams can improve patient outcome, prevent medical errors, improve efficiency, and increase patient satisfaction. Next, please. So why are we talking about communication catalysm, catalyst, which makes our communication faster? Management has often forgotten that business transformation is accelerated and achieved through effective communication, conversation bonds, and propels the organization. Working with hospitals for the last 20 years, we have learned that communication can alter conduct and unleash unprecedented value. I know that using the conversation technology to transform every leadership action into value for patients, physicians, and nurses. The catalyst communication explores the normally taken for granted world of conversation with insight, action, research, and pragmatic tools. Can we move on? Yes. The patient will never care how much we know until they know how much we care. Extensive research has shown that no matter how knowledgeable a care provider might be, if he or she is not able to open good communication with the patient, he or she may be of no help. Can we move on, please? Team structure. Healthcare is nothing but team. The ratio of the V's to I's is the best indicator of the development of a team. Next. Team structure. We will have to have a common purpose, and that has to be the patient safety goals, patient satisfaction scores. Common purpose, performance goals, mutual accountability, clear roles and responsibilities, complementary skills, interdependent tasks. Team skills are the result of effective team structure. So we have the three corners of the pyramid, that is the performance, knowledge, and the attitude. Very, very important. If communication is sans attitude, then the communication's result will not yield what we focus on yielding. So leadership, communication, mutual support, and the inculcated the ISBAR that is there. That is the introduction, the situation, the background, assessment, and the recommendations will come together. Moving forward. Now, what was the traditional management and what is the management now? The inverted pyramid of control. Initially, it was the doctor, the nurse technician, and the customer, the patient. Today, our customer is the top priority, then the nurse technicians and the doctor. So it is bottom up rather than top bottom. So why I have included this slide is the next slide will tell us why it is included here. Next, please. Partnering with the patient is very important for patient safety. If me as a patient doesn't know what is happening, know why my safety is required. If for falling, I would feel that I'm in a down. If ever my safety, I will not do. Embrace patients as valuable. Listen to the patient and learn patient's preference regarding. Ask patients about their concerns. Speak to them in lay terms and what is being spoken to. And ask for answer back. Have you understood? So get a feedback from them. Give them access to relevant information. Encourage patients and families to proactively. That is shown in the show me method, which 3 questions were there, which is not what ask me the 3 questions. To what do I need to do now, which inculcates around everything to him or her, if that is whatever nursing care is being. 3 questions, then the patient's comfortable that these are done for his improvement, for his cure, to bring him back to the state where he would not require hospitalization. Moving on, please. Yeah, now it's evident. What is my main problem? What do I do? Yeah. Group versus team. So working group, clearly focused leader, whereas team, share leadership roles. I always feel, and I have always shared with my team members, that when a nurse is allocated for a patient, she becomes the chief nursing of that patient. I hope my listeners are agreeing with me. Individual accountability moves on to a team, right? Individual work products, no. Collective work products. Efficient meetings, no. Problem solving meetings. Indirect measures of performance, no. Direct measures of performance. Decide. The essence of a team is common commitment. Thus, communication in healthcare and teamwork is very important, as laid down by Zenbach and Smith in 2005. Moving forward, there is a process, system, and structure which influences health. In that system, we are not individual. If we become individual, you remember our heart is a all or not none function. So it contracts and it dilates, right? So if it becomes individualistic, we will have ectopics, the arrhythmia. We want rhythm. So when we are in the process in the system and we are in a structure, if you want to influence the healthcare system in positive manner, we will have to be in a team form. We will live in the system, structure, systems.
Ms. Shanta, I think we are having issue.
And the system and the structure live in us. The structures are not neutral. They enhance, we all deal with lives. So that or fast communication is very much needed. What is right? But we have to, all performance are communicating up and up
I think the speaker is having some network issues. So what we will try and do is to move on to the next speaker.
And to get the
try
permission protocols have to be very, very crystal clear. That leads to workload, conventional teaching styles, lack of role of sharing.
So let us move on to the next speaker. We will try and get back Vishanta once again. Ankit, if you could play the video by Mr. Howard Catton, he will be speaking about capability at point of care. Ankit, if you can have the video, please.
Of nurse. Hello, everyone. This is Howard Catton, Chief Executive Officer at the International Council of Nurses, and I'm delighted to be able to join you for this series of important webinars on patient safety and medication without harm. I bring greetings from the ICN President and Board. For those of you who don't know, the International Council of Nurses is the internationally recognized voice of nursing. We have more than 130 national nursing associations representing the world's 28 million nurses. And we regularly work with or in the same forums and meetings as the International Alliance of Patient Organisations, and Carol Dipp in particular. He and I are often on similar events, a really important voice for patient organisations, and I'm delighted that both IAPO and the Patient Advocacy Academy, the Patient Academy for Innovation and Research, are hosting these events. Nurses play a role right the way across the spectrum of medication administration through to ensuring compliance and monitoring side effects. So whether it's prescription, whether it's dispensing, whether it's administration, whether it's monitoring, you will find nurses at all of those points. People often overlook the fact that nurses increasingly around the world are taking on prescribing authority for a range of medications, and that may be antibiotics, it may be painkillers, and increasingly that's a really important component of the nursing role, particularly when nurses are working in more rural and remote places. But of course, all nurses have a responsibility for both dispensing and administration, ensuring that the right patient gets the right medication, the right dose via the right route and at the right time, and also that the nurse and the nursing team then monitor for any side effects or for compliance as well. And a hugely significant issue for us in relation particularly to dispensing and administration is the patient environment and the working environment for nurses, as to whether those are conducive to safe medication administration. By that I mean, we know that there is a huge shortage of nurses around the world. Many nurses are working with shortages. Those have been made worse as a result of the pandemic, with nurses who were on sick leave as well. The working environment can often be very busy, and that means that there are risks that nurses who are administering medications can be distracted or can be called away, and that then may increase the risks of an error in relation to the dispensing or administration of medication. So for us, the working environment for nurses and ensuring that there are enough nurses with the right education and the right experience is also a key component to ensuring the safety of medication dispensing and administration as well. I mentioned before, but we shouldn't also overlook the role that nurses play with ensuring that any side effects are spotted quickly and early, or indeed whether the medication is having, you know, the desired and expected effect. And often these are roles that not just nurses in hospitals, particularly nurses in community and settings within people's own homes, play an absolutely critical role in ensuring ongoing monitoring compliance and identifying early and quickly any side effects that may arise. And in those parts of the world where fake medications is a real issue, then it is often the nurses who either spot that there is something wrong with the way in which a medication is packaged, or that somebody becomes unwell as a result of taking a medication, or that somebody takes medication that's having no effect at all, and that highlights an issue. And we've had numerous cases where it's been nurses who were first spotted what has turned out to be the use of falsified or fake medications. Another key component for all of us, and particularly for nurses, is also when errors occur in the administration of medications. And when that happens, that error is reported quickly, openly, transparently, and that appropriate action can be taken. We have been deeply concerned in recent days. You may have picked up of a case of a nurse in the US, nurse Randonda, who made a medication error in her workplace, but has been subject to legal proceedings and has just in recent days been found guilty of causing criminally negligent homicide by administering an incorrect drug. This case worries us hugely because the nurse did report the error when it occurred. And when you look at some of the details of the case, there were problems in the administration system of drugs within the hospital that meant that the nurses were overriding routinely some of the safety procedures that were in place. There were issues with the working environment and shortages as well. And this criminalization and blaming of an individual nurse when an error has occurred, and there are clearly system-wide issues where the error has been reported openly as well. We fear that this could have a chilling effect, not just in the States, but right the way around the world in relation to nurses and other staff reporting errors, genuine errors, when they occur. There's been a significant reaction from nurses in the US to this case. The sentencing is in a few days time, but we've also seen it in other parts of the world. I worked in the UK over the course of the Mid-Staffordshire inquiries, and you will know that the culture and creating a non-blame, open, transparent culture was absolutely critical to the findings and the recommendations that Sir Robert Francis made. These issues around the cultures, the systems, the working relationship that nurses work within are critically important to creating a safe environment for patients as well. For all of those reasons, we are, of course, delighted to be able to again be joining global efforts on the forthcoming World Patient Safety Day, which is going to be focusing on medication without harm. These issues that I've described to you in relation to the role of nursing, the nursing workforce, how we can support nurses, how the health, the safety, the well-being of our healthcare workforce and nurses are two sides to the same coin, to patient safety and patient well-being. We'll be advocating and we'll be promoting all of those things as well. We don't take for granted in the nursing profession the high levels of trust that around the world there are in nurses. Poll after poll shows that we're come out top as being, trusted by people, by the public. But as I say, that we don't take for granted, because we know it is based on the strict adherence to the ethical codes and the principles which underpin nursing practice, which is about working in a patient-centered way, which is about being, open and transparent and working in partnership as well. And our commitment will be to continue to do that. But there are some real challenges in the working environment that nurses face, which we also believe it's critical that they are addressed. To strengthen our health systems requires investment in our nursing staff as well. Thank you very much for the opportunity and to share some of the issues in relation to medication safety from a nursing perspective. I'm sure that your seminars will be hugely important in terms of driving this agenda forward. And from ICN and from the global nursing profession, we absolutely are committed to continuing this journey for patient safety and improvement with patients around the world and with your organisations as well. Thank you very much.
Thank you, Mr. Catton. And you raised a very, very important point about transparent, blame-free culture, which Dr. Srivastava had also alluded to. Also, another important point that you raised is very often falsified medicines that are not producing the desired effects or are producing harms are spotted by the nurses because they notice that the patients aren't responding well or are getting sicker. And therefore, they have a very important role to play in identifying whether the medication that's being given is actually doing the job that it's meant to do. So thank you so much for highlighting all these skills. Also, the fact that if there is criminalization and discrimination and people are not allowed to report, then there would be fear among the nursing staff and other healthcare professionals, and probably, incidents that are genuinely reported will not be reported in the future, and therefore the importance of creating that transparent, blame-free culture within hospital systems and within the healthcare, especially in terms of identifying systemic lapses and gaps and then strengthening them so that people are motivated to report patient harm. So thank you so much for that. We move on to our next speaker, who is Ms. Arshia Bhandari, and she will be speaking about incident reporting and learning. So over to you, Arshia.
Everyone, am I audible?
Yes, you are. Please continue. And if you could change this to a presentation mode.
I'll do that. All right, yeah. First of all, thank you very much for inviting me for this event. It's an honor to be here, and it was really wonderful to listen to such insightful presentations on patient safety from the previous speakers. So what I would be taking would be incident reporting and learning, and specifically related to the medication error, because that's what we are dealing with today. So at the outset, I would like to show you this news piece that was very recent from December 2021 about the cough syrup deaths that happened in 3 kids and about 16 kids who fell ill due to a dosage of a cough syrup or a bad batch. So there was a probe that was ordered by the health ministry, and the doctors were suspended for some time until the probe was over. The batches from that pharmaceutical company whose drug that was were withdrawn, and the drug was banned for some time from the market. So, so this news piece is from 23rd December 2021, and when I was searching it, I saw that there is no other news or no follow-up news after that. So the probes were ordered, the reporting has been done, but as a patient or person who's watching what happens next, for me, there's no conclusion or a resolution. So I think this emphasizes the importance of reporting as well as learning. And this is what we are going to talk about, because we know there is a probe that has, and I'm sure the probe is being done and investigations are underway. But as a patient and different stakeholders are also looking to what is the eventual learning and what is the communication to various stakeholders so that such events or incidents do not happen again in the future. So just to give you a perspective about the impact that medication errors have, these are a few statistics. So the Institute of Medicine report talks about 44,000 to 98,000 annual deaths worldwide due to medical errors. Of these, 7,000 deaths are due to medication errors. And I would agree with Dr. Ratna when she said, in the beginning that the exact number cannot be calculated because, it's underreporting is something that is very, very prevalent, and we cannot really say what exact. And of course, as you said, there's this the classification of what is a medication error would also contribute to these numbers only as estimates. Then estimated 237 million medication errors per year are seen in England. NHS costs, extra medical costs for treatment and management of adverse events due to these medication errors is around 98.5 billion per year. At least 1.5 million Americans sustain harm because of medication errors. The extra medical costs there are $3.5 billion annually. And when we talk about India, estimated 5.2 million medical errors in India are seen annually, and this is from a BMJ quality and safety report by Dr. Arshia Bhandari that was published. 3 million preventable deaths. Of these 5.2 million, there are 3 million preventable deaths. That is the stats that we have in India. But of course, due to the lack of reporting, efficient and effective reporting system and the absence of data registration, the exact number of medication errors is difficult to find. Let's come to what WHO, the strategic framework of the Global Patient Safety Challenge that WHO has outlined. And it was a 5-year challenge. And as you see here, we have, there are different domains, 4 main domains that are there, where patients and public stakeholders and the healthcare professionals. And incident reporting and learning is one of very important subdomains for healthcare professionals. And when we see here, reporting by patients and patient engagement, that is important. So how does the incident reporting and learning happens and what are the systems that are there? So as you see in the slide, so one is, of course, the hospital and national incident reporting and learning systems. If we look at every teaching or medical hospital would have an incident learning and incident reporting and learning system. How effective the systems are is a different thing altogether, as in it depends from country to country. And if we talk about developing nations like India, we're still a long way to go, as Dr. J.N. Srivastav shared in his presentation. So one is the incident reporting and learning systems that are implemented in the hospitals and the medical teaching hospitals. The research that is done based on these and the literature that is there based on these reports. And second, and a very, very important role is what pharmacovigilance plays in that. And pharmacovigilance is drug safety reporting. It is after, majorly after the drug has been marketed the drug has been marketed, so post-marketing studies and the spontaneous reporting that happens after the marketing of the drug. And who can report there is, of course, the consumers, the healthcare professionals, and there are different reports on literature, social media reports, everything goes into the pharmacovigilance system. Going on to the next slide. So what is incident reporting and learning? So to briefly share with you, incident reporting is defined as written or verbal reporting of any event in the process of patient care that is inconsistent with the deserved patient outcome or routine operations of the healthcare facility. Intuitive patient safety, incident reporting and learning systems which capture and provide structured learning are key to improving patient safety and preventing the occurrence of harm. And I would like to share here a quote from Toolkit Faculty, Patient Safety Institute, Canada, that I really resonated with. It says, to close the safety gaps in a hospital, first, we need to know where they are. Reporting systems serve as a map to show us where the gaps are and guides us in how to close them. Then, what are the basic principles and purpose of a patient safety incident reporting system? First, of course, is the report all errors and near misses. That's something that is very important. It's not because if we see in the hospitals, usually the reporting would happen for sentinel events or for never events which could have caused deaths or serious events, and the investigations or probes would be done because of that, as we saw in one of the cases in the news piece that I just showed in the beginning. But near misses is also somewhere we are, where a lot of learning is there. Because what was the reason of the near miss? Was it a human factor? Was it the systems factor that were involved in it? Or other factors that caused a patient safety incident? Then, of course, the learning, identify and investigate causes of errors, use them as learning opportunities, share, discuss with others and promote learning. Act, make changes to the practice, review changes to the practice. This is very, very important, and because reporting and learning is of no use until it is communicated to the right stakeholders and future incidents are mitigated. So stakeholders, of course, healthcare professionals and hospitals, national regulatory authorities, marketing authorization holders, that is the pharmaceutical companies, patients and general public. So here I would like to share something very important, that what is the importance of sharing patient and reflective HCP stories. When we talk about, and this is something that Peer Academy is also taken on as an initiative, that why should we share patient stories? It's when you look at it, a story is, first of all, it connects emotionally. And when a patient tells their story, when I'm giving you statistics, as in 7,000 deaths happened, it doesn't make that kind of an impact when you listen to what happened to that one patient and how it impacted the family and the life of that patient when an error happened. And this is something that has been, the research has shown that through patient stories, the healthcare professionals have been really able to understand the intensity of a medical error and how important it is to mitigate them as much as possible. Here, there's a very recent initiative from PVPI Pharmacovigilance Program of India. So there's an institute, CSTIMER. They shared an ebook. They released an ebook where they did reflective writing, and the clinicians, university clinicians from the institute, they did reflective writing on the adverse drug reactions that the healthcare professionals had seen during their practice and how it had affected them and how they, what happened, it was kind of reflections, what happened, what went into their mind, how it changed their perspective, and how in future they've been able to, administer safer healthcare safer healthcare to their patients. So these are some of the experiences that they have shared and how it changed their thought process. Then let's come to what are the national reporting systems and throughout the world. So in UK, we have the National Patient Safety Agency and the National Reporting and Learning System. And National Reporting and Learning Systems has under it many organizations that send regular reports to them. They analyze the medication error reports that they receive and they give recommendations. And just to give you an idea, this is the page that they have. One can select the organization, select the date range, and find the kind of medication errors that have happened in these institutes and how, what kind of learnings they've had and what kind of changes they've implemented in there. So it's a very organized system, and this is something that I feel that every nation should implement. Then let's come to the National Reporting and Learning Systems in the US. So we have NCC, MERP, then ISMP, that is the Institute of Safe Medicine Practices. So Institute of Safe Medicine Practices has consumer medication error reporting form. Also, it has the reporting form, a different reporting form for healthcare practitioners. And these are web forms. And similarly for the NRLS, there are web forms where patients can also report. Also, from the pharmacovigilance point of view, we have MedWatch online voluntary reporting from FDA, where patients can send their reports on medication errors so that the learning can happen and analysis of those reports can happen. So what if we talk about the national reporting and initiatives in India? So this is the National Patient Safety Implementation Framework that was released by the Government of India. It's a 7-year plan, and this is we are part of GPSC, Global Patient Safety Collaborative, and we became a part of this collaborative in 2019, and we collaborate with WHO and UK Imperial College to take forward this initiative on patient safety, and it's a detailed guideline on how the patient safety implementation will be done in India. Also, the pharmacovigilance program in India. So if there's a question on where to report, this is where we report if there are any adverse events or medication errors, and it is open to both the healthcare professionals and to the patients. So when we talk about classification of patient safety incidents, so a patient safety incident, does it reach the patient? If it doesn't, it's a near miss. It reaches the patient, it could be a harmful incident, that is an adverse event happened because of that, or a no harm incident where no AE happened. Was that harmful incident preventable or was it non-preventable? Again, this is also the index that NCC MERP gives for categorizing medication errors. Due to paucity of time, I won't go into details of this, and I think anybody who would like to refer to it can go to the National Coordinating Council of Medication Report and Error Reporting and Prevention site. Then what are the causes of medication errors? The human factors, the system factors. Abbreviations is one of the most prevalent causes. For example, HCT is an abbreviation that is used usually for hydrochlorothiazide, and sometimes a physician could write HCT for hydrocortisone, and the pharmacist or whoever is dispensing the medication can get confused. The oral orders, instead of writing the order, it's written orally. Look-alike and sound-alike drugs. Dosage calculation at source, which is incorrect. At-risk populations and at-risk drugs. So at-risk populations could be geriatric, where polypharmacy is there, or pediatric populations where the dosage calculation could be incorrect. For example, we saw in the incident report on the news piece that I showed just in the beginning. Then again, there can be ample causes of a medication error. The wrong dosage was picked, form was picked, drug was wrong, inappropriate, incorrect dose, drug dose was excessive, frequency or schedule issue, transcription error, drug was given to a wrong patient, it was contraindicated for certain patients. For example, there are many drugs which are contraindicated in pregnancy. And I would be taking one example where I'll be talking about it, irrespective of so much of communication that has happened in EU for valproate. This drug still is given in pregnancy, and and there are ample examples like that. Drug prescribed despite an allergy, incorrect route or form, drug dose omitted, therapeutic duplication, excessive length in therapy, miscellaneous, other reasons that could be there, and of course the drug interactions. So just an example of the look-alike and sound-alike drugs that lead to medication errors. This is the FDA published list on LASA drugs. So this is one example of how misleading the packagings could be, and these are look-alike drugs which would easily have been dispensed by the pharmacist, and if the patient is not careful, the medication error just happens. Then again, these are as you see, these are the established name and these are the recommended names that FDA is saying. There's a tall man lettering that FDA recommends for drugs which are sound alike. Again, this is the Swiss cheese model, and I'm sure everybody understands the basis behind it. So if we see the Swiss cheese model, there are different layers, and it is when these layers are going to align, the real safety incident it actually happens. So these different layers can be at different levels, which could be at the HCP level, where, so if we see this example, a resident prescribes or orders a clonidine dosage that was 30x too high, that is, it was an overdosage. The check was not done at the CPOE level, and no information was available to the resident on internal dosing of clonidine. So, this was one miss that happened. Now, it could have been saved here, where the supervisors could have caught this. It did not happen. They did not catch the order, and the task was not communicated. It went to the pharmacist level. This was another layer. It could have been caught with the pharmacist, but the pharmacist was also unaware of the indication of the internal clonidine. And eventually it goes to the last layer, where no check of dose was done during the daily rounds of the physicians in the hospital. And I would add another layer to it, though it's not given here, and that is the patient layer. Had the patient been aware, and this is probably not a simple, not a drug which is very common where a patient would be aware. There can be drugs which are very common, and if the patients are aware, the last layer could save the incident from happening. Then I would like to talk about an Indian scenario, and I would take a few examples from which we would understand how important the incident reporting and learning is. So first of all, this is a prospective observational study from India, which was conducted in 2020. It was a 6-month-long prospective observational study. It was done in a critical care unit of a tertiary care hospital. It was the method was medication chart review. There were a total of 6,705 charts that were reviewed, out of which 410 medication errors were found. And these are the results. The transcription errors were 44.1%, prescription errors were 40%, administration errors are 14%, indenting and dispensing errors were 1.5% and 0.5%. And then drug class, antibiotics and antihypertensive agents are most prone to medication error. About 87.1% errors belong to category B of National Coordinating Council of MERP risk index. So you can see, lot of learning could happen from this data, so that such errors could be mitigated or prevented in the future. So if I give an example, there was a report which I took it from a WHO document, that in one period of time, deaths in hospitals around the world were occurring because patients were inadvertently being given high doses of potassium during intravenous infusions. And the learning and solution to it was, at that time, that reducing the risk involved locking up in cupboards the strong potassium chloride formulations and only issuing them through special authorization. This was a process design solution to that particular accidental cause of death. So if you see here, it was recognized that was a system error probably, because it was so accessible. It was so accessible, and because of which these were taken inadvertently by the HCPs and administered. And this solution reduced the number of these medication errors that were happening earlier. Then there are several case studies. I won't go into details of this. Maybe I'll take one each, for example, to really understand what kind of learning can happen. So this is a case of a 73-year-old man with a history of cardiac arrhythmia who presented in the clinic for a routine follow-up visit. He was prescribed and was given a handwritten prescription of Rhythmol 150 milligram, which he had been taking for the previous 3 years. After filling the prescription, the clinical pharmacy, and he subsequently started to experience nausea, sweating, and an irregular heartbeat. After 2 weeks of symptoms,
wind up, please.
Sure.
Yeah.
So, and he called his physician for an appointment, noting that his Rhythmol tablets looked different than last time. When evaluated, the physician discovered that the patient incorrectly received Synthroid, levothyroxine, from the pharmacy instead of the prescribed Rhythmol 150 milligram. So the problem here was that the prescription filled by the pharmacist was attributed because on the prescription copy, there was an error, then unclear handwriting. And these were the prevention or the solutions that were recommended. Then I would just take one more example here, and that how PV incident reporting really helps. So from 1998 to 2000, these 4 drugs, terfenadimine, and were removed, and these 4 drugs were removed from the US market or restricted in their use, since their co-prescription with interacting drugs had resulted in deaths. Each drug had value in their pharmaceutical marketplace and for patients. However, they continued to be prescribed in an unsafe manner, even after warnings from the manufacturer and the FDA. Consequently, the risk associated with their continued widespread availability could not be justified. And again, another example that I've already given was about the valproate drug epilepsy, which still gets prescribed in pregnancy and causes congenital abnormalities. And in 2018, the PRAC of the EMA recommended new measures to prevent valproate exposure in pregnancy, and these measures are underway, and a report is expected in the next year. I'll now go to directly, I'm almost winding up. So what are the barriers of medication incident reporting, medication error incident reporting and learning? And this is something that has already been shared by the previous speakers. One was worry over legal ramifications, blame and shame culture that could be there, the lack of time to report, cumbersome reporting system, no trust in follow-up or repeated errors with no follow-up. Already reported the HCP or the healthcare worker already reported the same event in the past, and they don't see a requirement to report it again. This is something that is there with the pharmacovigilance system as well. That adverse events, the non-serious adverse events, do not get reported because the physicians or HCPs think that they've already been reported amply and they are expected. So details are lost with time, and eventually lack of encouragement from administration or colleagues to report. So this is one study poster presentation that happened, and it's very recent. It was a survey of medication error awareness and experience among physicians and nurses in tertiary care hospital settings. And it was a cross-sectional observational study. Sample size was 130 physicians and 150 nurses. Questionnaires were given to them. These conclusions were drawn from this study, that the major lacuna lies in documenting medication error experiences. There is awareness with physicians and the nurses about medication errors and the need for reporting, but still medication error documentation doesn't happen. And one of the major reasons was fear of negative consequences in subsequent administrative or legal action. And so they concluded that medication error reporting system is need of the hour due to the extent of harm it causes. Again, this is an example that Dr. Howard already shared, and I just wanted to share it again from the perspective of it, how difficult it would be for the healthcare workers or healthcare professionals to keep reporting if the criminalization of medication errors happens. And this is a very recent case where Rhonda Watt, a nurse, has been convicted for homicide, and because she injected the paralyzing drug vecuronium into a 75-year-old who then died because of that. She died. She reported the incident herself, and this is a quote that is given by Lambert, Dr. Bruce Lambert, director of the Center for Communication and Health at Northwestern University. He says it was extremely concerning that what was being criminally prosecuted for a medical error. This will not only cause nurses and doctors to not report medication errors, it will cause nurses to leave the profession. And so this is a precedent that we should not set if we want a healthy reporting and learning system in our country and in countries abroad. Again, patient engagement is one of the key factors that can mitigate medication errors. This is a simple checklist that patients can have when they're taking medications. This is again my concluding slide. This was my first slide, and this is again my concluding slide. And I would say these incidents should never happen again. And what is the need of the hour is an effective medication error and reporting system in our country, so that patients are safe and we could really depend on our healthcare system. This is for more reading, my references, and thank you so much.
Thank you, Arshia. That was a fantastic presentation, and a lot needs to be done for healthcare professionals, for patients, everybody to report in a blame-free environment, so that more and more incidents get reported, and that leads to better learning, better documentation, and lessening of harm to patients. So thank you so much for your presentation. We'll quickly take a couple of questions for the speakers. The first question is to you, Dr. Srivastava. And we've learned over the last 2 years during our experience from the pandemic that the world has gone digital. However, our training programs haven't really ramped up to that level, especially with telemedicine, telehealth, and other digital tools coming into the healthcare system. So do you think that digital platforms can help support training and capacity building for healthcare professionals, especially the frontline? And are we missing an opportunity by not using the digital tools that are available to us for building capacities of healthcare workers?
Thank you, Dr. Ratna, for asking a very timely question. In fact, during last 2 years, many initiatives have been launched where the digital platform has been utilized to reach out to the facilities, to the healthcare workers, particularly for the large and diverse country like India or many other developing nations. So it would be important to, utilize this platform, but at the same time, there are multiple challenges as well in the digital platform. More so once we are talking about, say, healthcare delivery is a team effort, and that is where, besides imparting certain, say, knowledge, but when there are certain training programs which requires team building exercise, where the digital platform has its own limitation in the sense. So in fact, the health setting will have to develop its own module, which cannot be obviously too large, too long, because the person loses the interest and other things. Those are the limitations, but obviously there is an urgent need to utilize the digital platform to reach out to the every nook and corner of any health system or any country. Thank you.
Thank you, sir. Thank you. I think a lot of work needs to be done in that particular area, and it is all a learning curve for everyone. And hopefully, most stronger systems will be built around the digital tools. So, thank you for taking that question. My next question is to Ms. Shanta, and we know that transitions of care are one of the areas where most errors happen, especially when people are moving from, say, an ICU to a normal ward, or moving upwards from the wards to the critical care, or from one unit to another. So from maybe a surgical unit to some other unit. There is loss of communication, and that is when it happens. So, what can be done to reduce medication errors that happen because of loss of communication during transitions of care?
Yeah, thank you. Am I audible?
Yes,
Hopefully.
yes, you are.
Yeah, thank you. First of all, I think to benefit this process or minimize this error of moving on of a patient from one area to another clinical area, we have got introduced our ISBAR, that is the introduction, situation, background, and assessment and recommendation, right? And what I wanted to say in my presentation, I would say here is that it is high time we should inculcate the doctor's advice and comment, right? Because when to an ICU or an ITU bedside ticket, whatever he wanted to write and whatever medication dose has been written, which has to be transcribed in the medication card, or the registered medical officer is transcribing it to the medication card, that time itself below the doctor's note, he or she is mentioning her name and writing it down, has been transcribed and followed. Very important. So that that particular advice has, there is no missing out of it. But we do not inculcate nursing, physiotherapist, or anybody else in that phase of the medication sheet. It's high time we do that, because comment nursing care plan is also included, so we can always encourage and empower nurses, registered nurses, to have their comments. Next, if the medicine card is already there, while taking over and handing over, we will have to see that the ISBAR is maintained. That will help and prevent us from minimizing the care and medication errors related to handover and takeover from one area to another.
Thank you. Thank
Hope
you
I
so much.
satisfy the question. Yeah.
Thank you. Thank you so much. My next question is to Arshia. And Arshia, in your presentation, you did mention that certain countries have a system where the patients can directly report any harm or incidences of harm if they feel that, there is something that they should be reporting. However, this is not a universal system. So my question to you is there any mechanism where patients can report medication harm to, say, not a national level kind of a system, but instead of having, say, organizations like the pharmaceutical companies which have marketing authorization, they do have these incident reporting methodologies, and then the country level has its own incident reporting methodology. But is there a harmonized, a mechanism where patient doesn't have to report to several agencies, but just one agency? And is there any metrics that measures patient harm or the incidence of patient harm from the patient perspective? And if there isn't any, is there an opportunity to build one?
Yeah, so I would say in India, we talk about then there's no such system as of now. That's in my knowledge. But we have pharmacovigilance program of India, and if we talk about medication error reporting or adverse event reporting, this is now functional. Patients can report to, but of course that awareness has to happen that medication errors can also be reported. So the patients can report to the area monitoring centers. The first step to go to report to, of course, is your healthcare professional. And generally, it's the responsibility of the healthcare professional to report to the area centers or to PVPI. But it is the PVPI. PVPI has an online Android app that is functional, or there are helpline numbers that are there, which where the patients can report any kind of adverse events that they have experienced with the drug. About the metrics from patients' perspective, I don't think that is there. This is something that we really need to develop. And this is why I shared the examples from UK and from US on the medication error reporting and learning systems that are established there, and how reporting and learning happens through these systems. This is something that we can do in India as well. The starting point would always, I would say, PVPI, reporting to PVPI. And in conjunction with that, if the government of India, because the patient safety implementation framework has already been released, and it is a 7-year plan that is going on. If we have recommendations on different initiatives that can be taken for patient safety, I'm sure this is something that will be implemented.
Thank you. Thank you so much. So I'll just have one last question for Dr. Srivastava, and this is a question since I am a healthcare professional myself. Most trainings are very vertical in the sense that they do not really do team trainings, and patient safety is something where team trainings are very important. So how can trainings be modified or restructured so that trainings on patient safety look at teams instead of verticals like nurses or doctors, or even amongst doctors, the various specialties?
Thank you, Dr. Ratna, for raising a very pertinent question. And that is a challenge also, that when as a trainer we conduct, say, a particular training, when our group is homogeneous, as a trainer, our task becomes simpler. But at the same time, since the delivery of the healthcare as such in general, and more so when we are tackling the issue of the patient safety, medication safety, all of us agree upon that it is obviously a teamwork, that no person can, talk in isolation or alone. So I would personally feel that on certain, say, topics where the hardcore professional knowledge is required to be imparted, perhaps homogeneous group or a specialized group may work. But when we are going to talk about building building those bridges, bringing about the transparency, inculcating the team culture to improve group training, more so when we are talking about outcome audits, or whatever parameters that decides in those settings, that the team training would be important. Though I know it will throw certain challenges, but at the end of the day, it will bring about the more, say, transparency, knowing each other's task, and creating those bridges. And so that ultimately at the end of the day, what is important is that we have the better health outcomes in terms of the medication safety or the patient safety, whatever the domain we are trying to address. So I would prefer that we can take the mixed approach, and that would certainly work.
Thank you, sir. Thank you so much for those insights. And we would like to close this webinar now. We have had a very, very enriching session from all our 4 speakers, and my special thanks to Dr. Srivastava, Ms. Shanta Sahu, Mr. Howard Catton, and Arshia for bringing their insights to this discussion today. Thank you so much, and let us stay connected because this is such an important topic, and all of us need to work together to get the desired results. So thank you once again for joining us today. Thank you to all the participants. Thank you. Thank you, sir.
Thank you, everyone.